2020 has been a year of a devastating pandemic that brought the world to a complete standstill, but it has also been a year of remarkable scientific achievement. As we look back at the year we've had, I'm joined by some of the biggest names in public health in India today, and I would like to welcome them all. Dr. Gangandeep Kang is a well-respected virologist from CMC Vellore and Vice Chair of Coalition for Epidemic Preparedness Innovations. I'm joined by Dr. Randeep Guleria, a leading pulmonologist and director of AIMS. And I'm joined by Dr. Chandrakant Lahariya, a public health and a public health systems expert. What brings them together, of course, is a book they've written, co-written together in the year of a pandemic called Till We Win, India's Fight Against the COVID-19 Pandemic. Thank you all for joining me today, doctors. It's a pleasure to have you all here. I want to start with a really simple question. January 2020, a few weeks from when the outbreak was reported in China, did you really think we'd be sitting here a year down the line still discussing the coronavirus outbreak? Dr. Lahariya?
Definitely not. In January 2020, we had never expected that we would be facing the kind of pandemic which we have come across. However, about the pandemic, world was always warned about. In the last 12 years, there have been 6 health conditions which were termed as a public health emergency of international concern by the World Health Organization. The experts have always been highlighting and underscoring that pandemics are the realities of time. The epidemics and outbreaks keep happening, but the world need to be prepared. The disease X was discussed a few years ago by the global community. They did not know what the disease or which agent would cause pandemic, but pandemics were always thought of. But definitely in January 2020, nobody had thought that this would come so quick and such a large scale.
Dr. Guleria, the book takes us through the various initial treatments that and repurposed drugs and everything else that was thrown at the disease in hospitals across the world. And a lot of them were experimental treatments or repurposed to treat COVID-19 because we didn't have therapies to treat the new virus. How do you know when it's safe to try a new experimental treatment and even when it's not yet backed by evidentiary medicine?
So that's one of the biggest challenges when you have a pandemic with a new or a novel virus or any other organism. And this is what we faced in February of 2020, when we suddenly started seeing a large number of cases, starting off, of course, with the surge that happened in China. And at that point in time, a lot of us thought, what would be the treatment strategy if we had to treat the virus of this type? The National Task Force was also set up by the Government of India and by ICMR. But that point in time, a lot of data was emerging in piecemeals from China itself. And they were trying drugs which were being used for HIV, lopinavir, ritonavir combination, and others, on an experimental basis. I remember in the beginning, we did not have enough evidence. We looked at safety rather than efficacy as far as these repurposed drugs was concerned. If we were saying they are safe, but there is some data to suggest that they may have an antiviral action. That's how one looked at hydroxychloroquine to begin with, and other drugs which were then tried, including drugs like ivermectin and other combinations, immunomodulators like doxycycline or azithromycin were also looked at. And it was based more on, let's say, an expert opinion, if I put it that way, rather than a lot of evidence as far as the SARS-CoV-2 was concerned. But as we went along the pandemic, we did learn a lot. There was initially a lot of reluctance to give steroids because of the data that had emerged from the H1N1 pandemic, where there was an increased mortality being reported when steroids were given. But it became evident that this is different, and this leads to, after the viral infection, leads to what we call a hyperinflammatory response and a cytokine storm, and their steroids may be useful. There was a lot of controversy regarding other drugs. Remdesivir is one, the role of anticoagulants, tocilizumab, which is an anti-IL-6 drug, and other drugs which are used for cytokine storm. Till today, we don't have an effective antiviral drug as far as COVID-19 is concerned. And even remdesivir is a repurposed drug, which was actually initially made for Ebola outbreak. So I think it's a process of learning as when you have a new virus, but it's like you're building a ship while sailing. You have to start looking at what is available and then start trying that out. And in the meantime, also doing it in a scientific manner so that you can generate some degree of evidence. Still think we don't have a definite treatment strategy. What we have is better than what we had in let's say, January, February. And that's why the mortality has come down significantly. But there is still a lot of research that needs to be done to find a good drug.
While research is still on to find a good treatment drug, and the kind of development, another branch of medicine, which is the vaccine development, is completely different. The first genomic sequence was done on Jan 11, 2020. Very soon after, as your book narrates, a lot of vaccine candidates started working on it immediately. And we're now in a situation where we have 5 to 6 vaccines that have received some form of approval across the world, and it's frankly remarkable. But there are also concerns when something like this happens. When something happens at the speed with which this is vaccine development has happened, there's always concerns about safety. Dr. Kang, as someone who was in the midst of all of this, what is your reading? Does the public need to worry about the scale and the speed with which vaccine development happens?
I think the scale and the speed of vaccine development are a testament to vaccinologists and the science that has gone behind the development of the vaccines. You mentioned earlier that we got started really early with the development of vaccines, and I was looking back at my notes, and it was within 2 weeks of the sequence being released that the mRNA vaccines work really started. And where we are today is it's taken less than a year to get to a stage where we have 5 vaccines that might potentially be used in populations. And for the Pfizer vaccine, certainly there's been a very wide rollout in multiple countries already. So in terms of looking at safety, I think the things that we need to understand about safety is the difference between common side effects and the difference and uncommon side effects. So common side effects, which are things like, fever, redness, pain, swelling, those happen pretty much with every vaccine, and we've accumulated a fair amount of data for that. For the really rare side effects, it's very difficult to get that information in phase 1, 2, and 3 clinical trials. Maybe if it's 1 in 1,000, you'll be able to pick it up in a phase 3 trial. But what we are seeing, at least from reports in the media, with the use of the Pfizer vaccine, is a few cases of anaphylaxis, which had not been seen before in the trials themselves. Now, all of those cases have been well handled. There has been no problems because people are asked to wait for 30 minutes after a vaccine is given. So immediate adverse events can be dealt with. Now, if there is a safety event that occurs 1 in 10,000 people, 1 in 50,000 people, then obviously that is one that we won't be able to detect in clinical trials. And we will need to ensure that there is safety monitoring when vaccines start to be used more widely. And in preparation for all of this, the WHO and the governments of many countries, especially the government of India, have been making a lot of efforts to ensure that there is post-introduction safety monitoring. The pharmacovigilance setup has been strengthened. The national AEFI, Adverse Events Following Immunization System, has been strengthened. There is guidance documents available from WHO and India. You can't foresee every eventuality, but whatever preparation needed to be done has been done.
A large part of your book does delve into vaccine development and approvals, and the role that rapid development platforms and regulators have played in making this possible. I just want to bring, the current conversation that's happening in India around Bharat Biotech. I just want to bring that a little bit in. I know we're talking about the book, but I do feel it's important because your book has led to this conversation. So I wanted to ask, all three of you have a slightly different opinion on the regulatory approval given to the vaccine. Dr. Kang, you feel it's too early. Dr. Lahariya, I read a tweet in which you say Bharat Biotech met the requirements for EUA. And Dr. Guleria, you feel the interpretation is conditional approval.
So I think Covaxin has the potential to be a really good vaccine. It's an inactivated vaccine being made by a company that has a lot of experience with making inactivated vaccines. It's using an adjuvant that has not been tried before in humans. So that's something we need to monitor. But we know from phase 1 and phase 2 studies that there have been no major safety events. Right, so I think it has the potential to be a safe and efficacious vaccine. They have an excellent clinical development program, goes through phase 1, phase 2, and a large phase 3 study, much more than the kinds of candidates that are from technologies that have been developed elsewhere, but where the vaccine manufacturer might be here. So I think they are in an excellent position. The question is, at what point do you give approval, even a restricted approval? Now, to me, I think it's very important that we have both safety and efficacy data. I've worked with vaccines long enough to know that immunogenicity does not equate to the efficacy of a vaccine. So I'd really like to see some clinical efficacy data for Bharat Biotech before the vaccine is widely used.
Well, on this area, everybody has spoken and the opinion are widely known. Our key that if answers were that easy, then there would have been only one answer. So the interpretation are of course individual, but I want to flip it to a different direction. That as you correctly mentioned, that three of us have a slightly different opinion about the emergency use authorization. But three of us have come together to write a book where we share some of the common ideas, and everything which we have written is agreed upon. So that's how the opinion and understanding develops. So I would say that all three of us believe in a safe and efficacious vaccines. And this is the dialogue that kind of dialogue will bring or provide India the safe and efficacious vaccines.
The book talks about the need for multiple vaccines to work to meet the global demand for vaccines. This is in face of vaccine nationalism by rich countries who are buying up major stocks of Moderna and Pfizer vaccine. And India has a role to play in the midst of all of this. How do you balance our own needs for our own people, and how do you balance the needs of the developing world that is looking at India for providing a bulk of their COVID-19 vaccine? Dr. Guleria, I wanted your thoughts on vaccine nationalism and India's role in it.
So I think vaccine nationalism is something which is dangerous because of the fact that unless we are able to finish the pandemic globally, we will not be able to really get over the pandemic. It's not that one area the cases come down and it's over, which is classically what we've seen with the variant strain, which has suddenly caused an increase in the number of cases, not only in UK, but now it's spread to many countries in Europe itself. So it's very important that a vaccine program, which may be country-centric, also looks at its global responsibility. And that is something which is also there in the WHO document. And that I think this is a place where India can play a major role, because the vaccines that we are coming out with are the ones which can actually meet the need for majority of countries in terms of cold storage and transport. So therefore, it would be useful if we are able to try and balance this out. I'm aware of the fact that already there is a communication with our neighboring countries to supply them some doses as far as the vaccines which are being rolled out is concerned. So depending upon how we can balance this out, I'm sure at a high level this would be taken. But I think there is a need to be able to look at it from a global perspective rather than just looking at it from a national or regional perspective, because there are a large number of countries where you have a susceptible population, and unless they are covered, the pandemic is not going to go away.
Right. Dr. Kang, there's always a fear with a virus like the coronavirus and the mutant strains that you're witnessing in variants that you're witnessing in the UK, that the disease, there's no guarantee that the disease will not become an endemic disease. In a situation like that, what role do, how do vaccines tackle a situation like that? And are all platforms in a position to update their vaccine if something like that happens?
So I think the control of the pandemic should not depend on vaccines alone. It should depend on vaccines plus the measures that we've been taking so far. It's important to remember that vaccines are not a perfect solution, because no vaccine is going to work 100% of the time. And it's very unlikely that our coverage is going to be 100%. So the impact on transmission is going to be imperfect, at least when we start out. At a later stage, when we have control, we could think about even better measures of control moving towards elimination and eradication, but that's currently not really feasible. Now, when we think about variant strains, the mutations that arise and what that might mean for vaccination, it does mean that we need to be thinking about mapping much more carefully, tracking strains as they spread around the world, and trying to understand what the biological significance of those mutations really is. What are we interested in? Does this cause more severe disease? Does this spread more easily? Will vaccines or monoclonal antibodies, if we develop them as therapies, really work against these variant strains? Those kinds of questions can only be answered if we link the genetic information that we have with clinical and epidemiological information and validate what we are finding in the laboratory and model systems. All of this taken together will give us a better handle on what we need to do and when we need to modify either treatments that are antibody based or think about vaccines. Among the platforms that are based on sequence data, which are the mRNA, DNA, and viral vector platforms, will have the ability to modify their production much more quickly than the kinds of platforms that are based on either the whole virus or on the production of recombinant proteins.
Right. Dr. Lahariya, you talk about the triangle that moves a mountain in the book. How do you perceive India's response to the pandemic, and what learnings do you think we have from the pandemic that we can take forward to strengthen our health system?
Let me try to highlight two specific points. One is that the role of community participation in fighting pandemic. So we know that the strategy which has been adopted to fight pandemic is test, trace, and treat. However, what we often forget that the success of this entire strategy will be incomplete without the community or people's participation. We know that the same strategy did not work in Dharavi till additional approaches were followed to engage people and in the delivery of those pandemic services. In testing, people need to come to testing facilities. Tracing, people need to cooperate. And of course, treatment is successful when people come to those facilities early. If we are seeing the less number of cases, a lot of credit go to the community adhering to those COVID-appropriate behavior. This is a clear success story of community participation and community engagement. And that's what we see between European countries and United States of America, where the communities or people are not adhering to that behavior, and we see the current situation. In India, people have adhered. So this is a message for future that community participation for health is really essential. The second part which I want to highlight, since you read about the health system strengthening, I want to make an analogy with the all Olympics. The country which compete to host the Olympics already have a good health infrastructure or a good sports infrastructure, so to say. So Japan is organizing, or Tokyo is organizing the coming Olympics, which have been postponed, and they have invested $12 billion in sports infrastructure to organize the Olympics. This they have done in spite of the Tokyo city already had a good sports infrastructure. They organized Olympics in the past. So taking analogy from here, the pandemic has highlighted that the pandemics or health challenges in India are really big. And we need to really invest in the health infrastructure and health systems to prepare for the future. So if we want to prepare for the future pandemic, the learning from pandemic is that invest in health, strengthen health infrastructure. And we have a full chapter in the book which describes and details what specific action could be done.
Dr. Guleria, I wanted to ask you, for you, what has been the biggest learning that the hospital systems can apply from this pandemic to be better prepared? Not just for future pandemics, but for regular health systems, to ensure that access to health is not limited to a few in the urban centers of the country.
So I think, as has already been said, there has to be more investment, especially in the public sector. We are looking at support which happens not only at tertiary hospitals, but a lot of work was done at smaller centers, district hospitals and primary health centers. A lot of work was done by ASHA workers in terms of screening and doing the contact tracing. And similarly, many doctors in different parts of the country came forward and were involved in managing COVID-19, the risks that they faced. But there were a lot of constraints that they had to face because of the fact that the infrastructure was not geared up for a pandemic and it was already stretched. So most hospitals were already sort of, let's say, literally working at more than full capacity. And then suddenly to have a surge of cases because of the pandemic becomes a huge challenge. So one has to develop strategies first in terms of how do we improve our health structure, both in terms of infrastructure and human resources. Secondly, how can we modify that in terms of an outbreak or a pandemic which may happen? It may be not be a pandemic. I remember in 2006 and 7 we did a huge exercise in our hospital, and in Delhi there was the outbreak of dengue. Suddenly we had a huge number of cases coming. Anyone with fever would come in, and we had to convert our nurses hostel into a ward, a dengue ward. We had to make an OPD area into a fever clinic so that anyone could be screened there, and had to increase our turnaround time for platelet count. So we have to develop strategies so that we can be ready for any outbreak, whether it be a pandemic or something which happens in that area, with support from the lab. And that, I think, is the learning that we've had, that we have to get our infrastructure ready, both to manage the routine load that we have, but also have a plan in place that how can we sort of convert it or sort of purpose it for an outbreak if that happens. COVID has taught us a lot that there is a lot of things that we need to really work on, including things like infection control. When we started off, we realized that infection control is something which every healthcare worker has to be trained in. It's not only doctors, residents, or the faculty, but even the sanitation staff, even your security guard. And all of that is something that we've never focused as much as we should have done in the past.
Given the state that we find ourselves in, where there are a lot of conversations happening and there's global collaborations happening, can this space of vaccine development be applied to future vaccine developments for diseases that we're still looking to tackle?
I think this is one of the most exciting learnings of the past 1 year. The fact that we can make vaccines and make vaccines on multiple platforms this quickly. So that's been absolutely phenomenal. And globally and in India, the efforts that have been undertaken by scientists are incredible. The question really is, if it took us about 10 months to develop a vaccine this time, can we make the next vaccine in 6 months? Can we make the vaccine after that in 3 months, so that a pandemic never has to be this bad again? I think with the technologies and the science that we have today, all of this is feasible.
I just want to end on one question for all of you. You know, we are entering the most crucial phase of the pandemic, which will eventually bring us hopefully towards the end, as your title says, to be WIN, which is vaccine distribution. And I think there'll be a lot of attention paid to how these vaccines are distributed and reach the last man standing, you know, the most needy people. So in your I want to ask all of you, what role does a regulator at this stage have to play, which sort of ensures this rollout happens to the last man standing?
So vaccination program is one of the oldest and well-functioning government program in India. It started in 1978, and every year millions of sessions are conducted, and millions of children are immunized. So I have no doubt that India would do a fairly good job with sufficient planning and delivering COVID-19 vaccine or SARS-CoV-2 vaccines also. Along the same time, I want to highlight that this is our opportunity to reflect upon service delivery, not only for immunization but other aspects. The infrastructure, the planning which is being done for COVID-19 vaccination should be developed in such a way that in the future also those last for the future, and existing vaccines are also utilized by the people. It builds the confidence of people in immunization program service delivery, but in general government health service delivery. And we also need to pay some attention on effective communication, credible communication for vaccine delivery. But having said everything, India has a strong, robust immunization service delivery system. This is an opportunity to strengthen that, at the same time fight pandemic, deliver vaccines, and keep learning. Credible communication would be the key.
Right. Dr. Kang, as Dr. Lahariya said, credible scientific communication, and not just amongst the public, but also from the regulators to the public, and transparency. Would you like to end this conversation by commenting on it?
I think that, vaccines are a very powerful tool, but if vaccines don't reach people, then they cannot have the impact that they are intended to have. So it's very important that we understand that any products that are going to be widely used should be high quality products, should be safe, should be efficacious. And regulators in India, around the world, their responsibility is to ensure that the products that reach us are of that quality. Our regulators have determined that for 2 vaccines, and I hope that the vaccines, when they are rolled out next week, will be used. If you look at the communication strategy that has been developed by the government, it actually looks at vaccine eagerness, the hurry that some people have to get vaccines that may be in short supply initially. It looks at vaccine hesitancy and at programmatic issues. So that document is really quite a remarkable document aimed at building confidence in the vaccines that are provided by the government.
Right. It's a pleasure talking to all of you. You know, the book is a remarkable and excellent resource for journalists, for researchers, and for future students of science. So thank you for putting it together, and putting it together in the midst of a very, very busy schedule for all of you. It's been a pleasure reading the book, and it's been a pleasure having this conversation with all of you. Thank you so much.
Thank you.